Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. It gives us great pleasure this afternoon to have a world export and a wonderfully renowned Earth author called Sara Nasserzadeh, and she hails from, as we speak, California, Los Angeles. Sara, if you Google her or check out the Wikipedia, you'll see that this is an extremely accomplished author and presenter. Her CV is very long and very involved and extremely impressive, and it's wonderful that we can have a person of this caliber with us this afternoon. Sara is presenting on an interculturally informed provider, sexual culture, what informs one's sexuality, and intercultural perceptions around sexuality. As you could perhaps see from her name, Sara hails from Iran. She's an Iranian American, but she trained, in fact, in Middlesex in London. That's where you trained, Steve. You come from Middlesex, don't you?
No, I didn't train in Middlesex, but I did work in London as well.
In St. George's Hospital.
Yeah, that's St. George's Hospital.
That was many years ago. In fact, he was friendly with St. George's that long ago. Sara, it's wonderful to have you, especially as you must have woken up very early. There's 9 hours difference between Cape Town and Los Angeles. So it gives us enormous pleasure to have you with us this afternoon. Anybody that Googles Sara's CV or Wikipedia's it will see that it's enormously comprehensive. You've been on practically every cultural body, every sexuality cultural workshop. You've done wonderful work with marriages and family therapy. So it's a wonderful privilege to have you with us, and we look forward to greatly having you. And this presentation is sponsored by the Pelvic Floor Foundation of South Africa. Next week, we have Dr. Tinya Wojno on, and she's speaking about STD guidelines on diagnosis and treatment. So without further waste of time, Sara, thank you very much, and it's a great privilege to have you with us, and we look forward to you sharing your slides with us this afternoon. A special thank you to our technicians as well, who've made this possible, and I will be doing CPD questions, so if you send them along and you get your CPD answers correctly, you'll be able to win one CPD point for this afternoon's presentation.
Yeah.
So my co-host this afternoon, sorry, you'll see him over here with me. He's Professor Steve Jeffrey. I rate him as one of the 10 best urogynecologists in Cape Town. So it gives us a lot of nachas to have him over here with us this afternoon, Sara. And author of Love by Design. I've also Googled that, and it's a wonderful presentation. So without further waste of time, Sara, this afternoon, welcome to Cape Town.
Thank you so much. Good morning, good evening. Thank you very much for having me. The honor is mine. And I hope that our colleagues walk away with something that they can use in their practices and in their personal lives as well. As I'm understanding, our colleagues on the call are mostly from medical background, but not physical therapies. So obstetricians and urogynecologists and GYNs, as I'm understanding.
That's correct. Right.
Beautiful, beautiful. So I wonder if in the chat, our colleagues can tell us, just knowing about this, even just judging by the topic of this call, when they were signing up for this presentation, what were their hopes? What is it that they would like to take away? So I make sure to tailor my talk to our colleagues here. As you're doing that, I will just go through the overall perspectives that I would like for you to have. So to orient us before we go to the actualities, and hopefully I get to answer some questions as well. Yeah.
Would you mind if people interrupt you to ask questions, or would you prefer to take them at the end, Sara?
If you don't mind, I will do the presentation just for maybe 10 minutes. And then after that, we'll go to the question and answer, because we could go to so many different places. It would be a good idea to have a base and then launch from, if it's okay.
So we won't launch down rabbit holes as people tend to do it. We won't go off piste. Okay, Sara, thank you so much for being, and we look forward to your talk. But
just for some clarity, would you like people to type into the chat or the Q&A just their sort of feelings about what they were expecting of tonight's talk, etc.? Is that what you're wanting?
Yes, please. Yes.
All right. Okay. All right. Good. Well,
So
thank you.
please keep the questions and thoughts and comments coming, and I will read them as soon as, you know, this first piece is done, so we can make the best use of our time.
Thank
Okay,
you.
Thank you.
Of course. Is it possible for me to share my a PowerPoint? Is it okay?
Yes, you can share your screen. I think there'll be a button there for you to use to share your screen.
Yes.
You got it there.
Do you see my screen?
Yes.
We do.
Beautiful. Wonderful. So this is just for colleagues who would like to get in touch with me, and you know, you can find me anywhere really. Just the spelling of my name if you want to just jot it down. So very quickly, as a reminder to all of us, that when we work within the field of sexuality, we need to really pay attention to quite a few facets here. So one is the biology, one is the psychological part of it, and then the other one is interpersonal and sociocultural, to say the least. This is just the biopsychosocial model that we have based on Rosen and, you know, other colleagues. But this is very easy to forget, especially if we only spend some time, like 10 minutes with a patient, 15 minutes with a patient. So that's why we always work within a group. So in England, for example, when I was trained, I was able to pick up the paper and pen back then, you know, 20 something years ago, and then actually write to the GP of my patient or client and say, hey, here's my observation. Would you please help me figure this out? Would you please reconsider the psychiatric medication that you're giving? This is impacting my client in a negative way in their sexuality. Can you please do a transvaginal ultrasound just to tell me if there's any polycystic ovaries going on, if there's anything organically going on? And then I moved to the US. We can't do that, because if I do that, first of all, the medical system doesn't work that way. And second, everybody's so afraid of the legalities of the situation that they don't even want to talk to one another. So what happens is that each of us is practicing in our own silo. So hopefully walking away from this session, depending on where you practice within Africa or other places that I don't know, I think we're mainly from Africa today on the call, you need to really have a team to work with any kind of sexual issues that come up. And we will cover some parts of it, but then hopefully you will be creative about your history-taking questionnaire, for example. If you don't have enough time to spend with your patients to actually ask them the clients orally and in person, at least when the intake form comes in, you quickly glance and, do you have any issues with orgasm? Yes, no. Do you have da-da-da? So, you know, so do that. And so that you can have a very good holistic idea. Otherwise, you might be treating just the wrong symptoms, to be honest. So this is just to present the holistic approach that we need to take. One example that I want to give you is what I call sexual culture. Everybody, including ourselves, we grow up within a context that within the culture of the family, within the culture of the community, the country, the continent, within the culture that we're influenced by, it could be social media for all I know, right? In this day and age. We have certain perceptions around sexuality that shape our beliefs. Within those beliefs, we also determine what is norm, what is not the norm. And if we abide by the norms, then we are rewarded usually. And if we go against the norms, we get negative sanctions. And within those, with that understanding, there are rules of engagement. So for example, what we do to our genitals, when clients come, patients come, we see what we see, right? Medical doctors who have the right to examine the patient, they are in a better place because they actually can see the organ that they're working with. But for me, as a psychosexual therapist, for example, I have to have even more thorough questions for them just to see the organ that we're talking about and is involved in those interactions. What is happening there? Is it dry? Is it wet? Is it teared? Does it have lesion? Does it have scars? What is happening there? And for you as medical practitioners, hopefully you get a chance, and also pelvic floor PTs, you will have a better chance to actually look at the organ. Within that, also, please have some of these questions in mind as you're working with your patients and clients. People have ideas of sex before marriage. Is it only allowed within marriage? Is it you are married, but you can also go outside the marriage? So, for example, a lot of cases that I hear from medical doctors that I train, they see multiple bacterial infections, yeast infection. Yeast is a little bit different, but specifically bacterial infection, HPV, and a lot of STIs that they report, a lot of irritations of the skin. And then, but then when they ask the client, are you married? Yes, I'm married. Then they don't really think that, okay, maybe there's an extramarital situation going on. But because within the culture, extramarital relationships are so taboo, nobody will bring it up. The patient doesn't bring it up, and maybe they don't know their partner is involved in extramarital activities. So these are the things that we need to find the language that is culturally appropriate for them to be able to feel safe and actually share with us. The other thing is, if the practitioner, depending on the gender of the patient and the practitioner, they might choose to share certain things with you or withhold certain information from you. Because if you're a woman practitioner seeing a woman married, having an affair, or the husband having an affair, imagine that situation. How is that woman going to disclose that to another woman within that culture who doesn't believe that affairs are okay, for example, right? So we need to also consider our roles, our age, our gender, demeanor, our specialty. Like oftentimes when I work in countries like Latin America or Middle East, they ask me to wear a white coat. And I don't like it because in England, we don't even call ourselves doctors because PhDs are not medical doctors. So we don't even say Dr. Sara, Nasserzadeh, right? But when I'm in the Middle East teaching urologists or working with patients within those clinics, if I don't have the white coat, I can't really allow myself to ask people questions. Do you self-pleasure? If it's coming from a doctor's mouth, it's okay, they will answer. But if it's coming from a woman, certain age, certain ethnicity, certain background, I can't even allow myself to ask that question. It could be offensive for my patients or clients. So you see where I'm going with this.
Yeah.
It's important, right, to be aware as what is it that we bring to the room and what is it that we are inviting with that presence and what is it that we are shutting out. The other thing is when the patient walks in, the way that they address us is very important. So for example, if a person comes to the room, I was working in Germany, I was professor, doctor, so many names, even before my first name was announced, right? In that situation, I am put on such a pedestal that I need to have all the answers. But in London, for example, when I go, work with colleagues there, I'm Sara. And you see the difference. So in front of the clients, I am not put on the pedestal to have all the answers. I am the expert, but I can actually easily say, I don't know, actually, let's figure it out together. But in Middle East, in Germany, I'm assuming in Africa, doctor is God. So it's like you can't really be in that exploratory mode. So that's also something I want to mention here. Now, acceptable number of sexual partners in lifetime it could be very different even within the same community. And we know that male clients, they boast about their sexual partners and the numbers and different wonderful things they do to each other. And for women, we tend to be modest. We tend to be, if we sleep with 10 people, we say, well, I only slept with 1%. So these are the things to have in mind as well. Monogamy versus polygamy. Is it polygamish? Is it monogamish? So there are so many different terms that thanks to social media, people identify with. And these are the things that are important. So I've had clients who, I had a case that the couple came to me, they didn't sleep together. It was presented to me as unconsummated marriage. So I'm working with the woman, And then when I saw them individually, I do that. I see them individually, which is not something everybody feels comfortable to do because it could be used against you in certain cultures. So I'm talking to the woman after 3 sessions. She tells me, I don't trust him. I think he sleeps with men. And then as I'm talking to him, he never brought it up because in that specific culture, men, it's just a male bonding. We have sex with each other, male bonding. They didn't even call it sex. So the woman was trying to protect herself. There was no vaginismus. There was no contraction. There was no nothing. She had no issues. It's just that she was psychologically thinking that, oh my God, he's going to sleep with all of these men and sleep with me. I'm going to get a CI. So that was the issue there, right? Same-sex sexual, right? Same-sex sexual encounters, like, is it recognized as a form of sexual behavior? Is it frowned upon? Is it, as I mentioned, like this client that I mentioned, homosocial behavior? And labeling sexual encounters might not work. Like, so you're telling me that you have sex with men. Are you gay? Are you bi? Are you poly? Like, what is happening here? Sometimes labeling it helps because it frees the person. They actually, the accountability of it, and you can treat them the way that is proper to that situation. But sometimes labeling it actually causes them to shut down. So please make sure that, the labeling doesn't work for everyone either. Now, some people get married to have sex. Some people get married because they want to have children. Some people get married because they think they fell in love with the person. And there are different reasons that people get married. And by the same token, there are different reasons for people to have sex. And what I find is our judgment is not helpful. Thankfully, based on my interaction with colleagues in Africa, I think the culture allows for diversity around this. In America, if a woman comes to me and says, I have sex with my husband because he buys me really nice things, then an American therapist might say, oh my God, you subjugated woman, let me free you up. But if that happens in actually the rest of the world, majority of the world, not the rest of the world, you can say, oh, okay, so how is sex? Do you like it when you do it? Is the currency worth it for you? Is it enjoyable for you? Is it painful for you? What is the meaning behind it for you? Maybe that's not the reason that brought them to us. So it's not my place to free up people, so that piece of it is very important. And I know that in Africa, we also have the genital cutting still in certain communities going on. So the genital cutting, I call it cutting for a reason. Unless the client calls it genital mutilation, or unless I'm at a UN advocacy meeting, I'm not going to call it mutilation, because a person came to me to see what to do with this organ that was cut. I'm not going to patronize them. I'm not going to put them down and say, well, you know what, you're disabled and you've been mutilated. Now let's see what we can do for you, poor person. Unless they use the language, I don't go there. So that's my personal opinion, just based on clinical practice. Alternative sexual gratification and behavior, the currencies that I mentioned, acceptable sexual positions. Sometimes patients come to you and say, we don't have sexual encounters. And we need to ask them, how is the way? I have 2 dolls in my office, and and nowadays online, I ask them to find the photo online, even 2 fruits having sex with each other, whatever that is suitable for them. Show me the positions in which they have sex. For example, if they have endometriosis, if they have congested uterus, if they have polycystic ovaries, if they have any sort of issues or constraints within the system, deep penetration hurts. And it's a dull pain. So helping the client to talk to us about what sort of positions they engage with and which one is more comfortable for whom, which one is more pleasurable for whom, and differentiate pain and pleasure for them. Because sometimes they feel when we take away the pain, the pleasure is there. It's not true. When we take away the pain, sometimes they actually grieve the pain because it served the purpose. So there are so many complexities in this area. When we are talking about sexual positions, we need to see if they are complaining of pain or lack of pleasure or diminishing of orgasmic feelings, we need to ask them to see, is it different when you are self-pleasuring? Is it different when you use your own hand, your partner's hand? Is it different if you do it in the shower? Is it different when you do it at night or in the morning? I've had clients who came to me and said, when we have a deep penetration at night, I have pain. And then I asked them, what is the cadence for your bowel movement? They said in the morning. So if you have a lot of feces in you at night and you choose to have deep penetrative sexual position, it hurts. It's uncomfortable. So these are the things that we need to help people also see themselves within the context of their lives, rather than just come and say that sex hurts. Okay, what type of hurt, right? So, and then sexual position is a big part of it. The other thing is, I've had clients who are very religious and they refuse to have sex with each other because it was shameful, that Madonna whore situation, that, I respect my wife too much to have sex, this kind of sex with her, or I respect my husband too much, or I don't want to lose my innocence in front of my husband, so I'm not going to just lie naked or have sex or whatnot. One thing that I find helpful is to go with them. So for example, there are 4 roles that I have for any kind of provider. One is the facilitator. You facilitate the patient's understanding of the situation. You do the exam, you help them, right? The second one is authority. Authority is doctor recommended. Can you please go home, take a mirror and look at yourself and see what you see? Or can you please have sex, come back, tell me how it hurts or where it hurts? So doctor recommended, authority. I use that specifically when there's resistance from religion, from culture, because usually doctor raises above, that, and it's for the betterment of health and betterment of the relationship, so people really might listen to you. And then the third one is delegator. Sometimes they say, well, in this case of my husband, I don't want to lose the respect, whatnot. I actually had multiple clients with that. I told them, here are the lists of sexual positions. Which one do you think is more graceful? Which one do you think keeps your innocence while allows you to be intimate with each other? And some of them chose missionary. Some of them chose doggy situation because they said, well, we're not looking into each other's faces. Whatever works for them, as long as the job is done, right? Whatever works for them. And then, so that's delegator, that they come up with the response. A delegator, I give you another example which might help you with your practice as well. And then the last but not least is demonstrator. So when you have moulage in your office, like a models, to show them, a lot of women who have vaginismus, especially in more contained cultures, they might even think that the penis goes and is going to get lost there. I've had that before. Or for example, you tell them put this cream on or lubrication or whatever that we give them, they refuse to use it because they don't know anatomy. And then if we can just show them that whatever that goes in, it stops at uterus. If you have if you have the cervix, then it stops there. It's not going to just get lost. Or when we are explaining to them why foreplay matters, why arousal before penetration matters, it's important for them to know that without that, they're going to just hit a wall. And, so just explaining that through that demonstrator capacity is important. So there were 4, facilitator, authority, demonstrator, as well as delegator. Now, with the delegation, I've had clients who were Hasidic Jews, and I needed to work with them, but they wouldn't touch each other. This is a heterosexual couple. They wouldn't touch each other for 2 weeks, a month, and I couldn't really get that much further with their problem, with the protocol. So one thing that I asked them, I said, well, here's what I would like to happen. I want consistent touch on you throughout the month. And then how can we make it happen? I called the rabbi, I talked to him, and they went to the rabbi. And funny enough, the guy in the couple then came up with the solution and offered it to the rabbi and said, how about if I wear surgical gloves and touch my wife within that 2 weeks of when she has her period and, you know, before she goes to mikvah. And then, so the rabbi agreed, and our problem was solved. We achieved what we wanted to achieve, right? And they came up with the idea. So that's a good example of delegator. Now, males and females' roles and expectations. Who is entitled to experience pleasure or orgasm? Who is, and a lot of people still believe that sex should be painful for women. And the more you endure, the more of a woman and female you are. So these are the things that, you know, we are working against, to say, hey, actually, no, this is for both parties. And I can't tell you how many times I said, you know what, sex needs to be enjoyable for everybody, at least pain-free for everybody. And my male clients within those circumstances looked at me and said, it's as if they didn't know that. It's really interesting, especially because we have a high rise of the aggression within the porn industry. And so that perpetuates this idea that men are the aggressors and women are not. So that's that piece of it. And then hygiene, guilt, and respect. Respect, we talked about it. Guilt is sometimes people don't enjoy sex, they feel guilty. Sometimes they do enjoy it, they feel guilty. So it's a very interesting mix between guilt and, you know, sexuality. And then the other one is hygiene. A lot of people, in the US, we have studies to show that African-American families and women use more of the vaginal douche. So vaginal douche, as you know, it will throw off the balance, the pH balance of the vagina. It could make it drier, depending on what they use. And also, sometimes people even use perfumes, actual perfume with alcohol in it. So we need to really be very clear. How do you wash yourself? How often do you wash yourself? And also consider this, that because they might think that you're judging them, they're dirty because they're not doing the good job. We need to put them at ease first and say that, you know what, we don't recommend for you to wash your vagina, especially inside of it, with anything that like a soap or shampoo or, you know, whatnot, and explain the natural release and cleaning system of the vagina, especially for women. So it's important for them. A lot of dryness we experience with that we need to know about. So with the hygiene, the other thing is the trimming. As a practitioner, when you see somebody coming to you, you can comment on the pubic hair. You can comment on, let's say, for example, they are doing Brazilian wax or laser or, you know, whatnot. As practitioners, I absolutely believe that this is our place to comment, because there are so many couples I see, they stopped having sex. When I see them individually, one of them says, well, I really don't like it when he does this. You know, he's bushy, I don't like it. Or the woman smells, I don't like it. So, you know, there are so many different things that they don't really bring up, but that is the actual issue. So as providers, I think this is absolutely our place to bring up the mannerisms, the way they treat their genitals and the hygiene and stuff. Virginity and hymen. It's still very important in specific communities. There are certain ways that we can remedy this. So one thing is, when people in Africa, just based on my readings of the literature, is less than America. So for example, in America, a lot of people, because they are pain averse, at the sight of a little bit of discomfort, the first sexual encounter, they go to the doctors and they ask them to surgically remove their hymen. What they don't pay attention to is who they go to. And also, you are all medical providers, you don't need me to tell you, but there are nerves. That place is packed with nerves. And also the way that the natural hymen will go away, unless it's absolutely necessary to remove it surgically, we are going to create false scars in that area. And a lot of people that I treat with dyspareunia have gone through the process of removing their hymens. surgically. So please, be aware of that as well, that, the aftermath of surgically removing the hymen as well. And or some people had sex before marriage. They were not supposed to. They are supposed to bleed on the first night or first sexual encounter. And they come to you and say, please sew it up so that I do bleed on the first night, so that I show that I'm a virgin. So there's a lot going on still there as well that we need to tease out as what is their idea around virginity and, the preciousness of hymen, so to speak. Fertility and contraception, who is responsible for the contraception, contraceptive practices within the coupledom if you're seeing a couple, and also fertility. Fertility is a big issue that will impact couples' sex life. Some people are afraid of getting pregnant. Some people are afraid of not getting pregnant. So there's always duality. Quickly visiting some of these, individualistic and versus the collective system. Africa, by large, is the collective social system, right? So when I was trained in England, we were told that if you have a client, you just look in, that person is your client. So you're focusing on that client. Little by little over the years, as I go through the world, working with different cultures, I am noticing that, hey, yes, this person is my client, but the mother drove them to my office, or that guy is controlling which medication she takes. And whatever that we are experiencing is going to impact and being impacted by the larger system. So in a collective system, we need to really know as who are the influencers in that system, whose voices are in the room. Although they're not in the room. Now, sometimes we feel like we give diagnosis, we relieve pain of the client. You know what? You're not alone. It's okay. We'll make it. There's a name for this. This is vaginismus. We can fix it. This is erectile dysfunction. Here's the medication. You can fix it. Beautiful. However, here's another thing I learned over the years. In certain judicial systems or, like communities, when you label somebody, that will have a ripple effect in the community. They could get blamed. They could expect a lot from what you're offering. So, for example, if there is a label, if there is a diagnosis for these, then as a doctor, you have to be able to fix it. And sometimes with sexual issues, we can't fix it, treat it. We can just manage it, right? So that is the piece of it that we need to be careful about it as well. Or for example, in the Middle East, it's very interesting. If you diagnose a man with erectile dysfunction, it carries on for a year, the woman can ask for divorce. So these are the things that we need to be aware of as who is referring the client, what is this diagnosis going to do to the couple, to the person. The session management, this is just the last piece, is importance of individual sessions. You probably see your patients alone. Sometimes you have to kind of drag the partner in. Sometimes it's helpful to have all parties involved. And sometimes you need to really see the person alone. And sometimes based on the ethical, moral, and legality of the situation, you can't. So you need to figure out as how to tease out the information that you need that is best going to help you with the outcome of your work. The dress code and setting, again, the white coat, as I mentioned earlier, sometimes it's helpful. Sometimes it creates anxiety for people. It depends as where you are. We don't have therapists here, so I don't go there. But some therapists, unfortunately, if you look at their Instagrams, if you look at their, the way they dress, they feel like because they are sex therapists, they have to be sexy, which is actually quite the opposite of what works for majority of clients. So this is just one thing that we see more and more of these days. And sensitive approach to domestic violence and sexual abuse. Although you might see a case of abuse, they might not disclose. And I'm pretty sure within our audience here, you've seen quite a few. One of the criteria, like dynamic that people have in abusive relationships is that they are very much enmeshed in one another. So you become the enemy sometimes. if you call it out. And sometimes you are the rescuer. You say it, and the person feels relieved that you saw what is happening. But if you don't have a whole system supporting you, like a legal and police, for example, you know, whatnot, you can't really call it out that publicly for the person. Like, you can't say that, like, for example, you've been sexually abused, you have to do this. We have to really put the person within the context. Again, non-disclosure, especially if a family member is involved. Let's say the person is being abused by their mother, by their father, and sometimes they don't even call it abuse. And I know that, for example, in parts of Africa, massaging of the boy's penis is common by the mother, by the grandmother. And so you can't really call that abuse within a certain culture. But for example, if you come to America, they might call it abuse. So it's a very important thing, especially in cross-cultural marriages or couples that you work with, if you ever get to work with the people. And what we call abuse, wherever you are, might not be considered as abuse. So we need to be very gentle, again, with labeling. Define the goals and success to be very clear what is achievable, what is not achievable. Because if we say, oh, easy, you have these, we're going to fix it. And then along the way, you figure that, oh, okay, so that was not the only issue, and other issues involved are not going to allow you to actually fix the issue. They just need to learn to manage it. And then the outcome of it is not only disappointment from you and your practice, but also they feel like they are broken. So when we false promise people that we fix something, and we can't, they feel like they are broken. And that's not a good feeling to be left with, because it's a part of their body involved. Now, opportunistic sexuality education, I cannot emphasize that enough. A lot of people, we are the only people who will ever talk to them about sex and their bodies and their genitals and reproductive systems. So please take that time and a privilege to educate people. And also about sexual response model, even if this is not an issue for them. They come for an exam, we are doing the anatomical testing, and then we say, hey, did you know we have two, like response models, a responsive and a spontaneous. Some people really want sex, they get horny, and then some other people, if they're touched in the right time, by the right person, they get aroused. And that could be pretty liberating for people. And the practicalities that we talk about, like the positioning and mechanics of sex and hygiene and giving permission, is the most important part of our work. I'm just going to stop there just to check in to see if we have any questions. And then how was this? Was this relevant? What was relevant?
Sara, this was extremely useful and extremely important and extremely relevant. Can I just ask, we have a few questions. One of the questions is this: you made the point about in some cultures, perhaps, it's important for the man to feel the woman should receive pain during intimacy. How would you change a universal misconception like that to banish ill-conceived ideas from cultural perceptions in that way? How do you change things? Because if you've got a huge culture, culture A, and the men feel that this is important for women to feel pain during intimacy, how would you change and approach that problem?
Thank you for the question. Depending on the person and their level of education, I might take different approaches. For example, in one of our books, Orgasm Answer Guide, we have a picture of people that we took, and it looks like the person is in pain. At the moment of experiencing orgasm, their facial expression looks like as if they're in pain, right? So I have that picture in my office and I show it to people and I say, well, that's very interesting you say that, because based on our research, people look like in pain. Look, even when you watch porn, When you watch all of this, like movies, when you look at the person's face, it looks like they are in pain, but that's because of the way that we express that level of pleasure when we are in that situation. So that is one way. But the reality of it is, anything that inflicts pain on us, our body doesn't like it. So if you would like your wife, or your probably that person maybe has an idea that only sex is within marriage. So if your wife keeps experiencing this pain with you, then over a period of time, although she loves you, she wants to be with you, she wants to fulfill the marital duties, but on the other side of it, her body might shut down, because every time this is really painful. So the better way to do this is to have it without pain, and even better to add pleasure on top. And the other analogy that I give people is, I ask them to imagine that there's a food that they really like. So as actually our audience here can do that too. Really think about the food that you like and imagine that you're eating that food. Make it as real as possible, like the texture, the taste, the smell, all of it. And you will see that your saliva is coming, right? So if you really roll your tongue around your mouth and imagine that food, your saliva is coming, right? Now, imagine that there is something that you really don't like, you despise, like food-wise, right? Think about it. And now think that you're eating it with the texture, smell, taste, and roll your tongue around your mouth. See the difference?
Yeah.
It starts to dry up. So I give them that analogy as well. That, it's not something that is intellectually, cognitively, relationally, the person wants to be with you. But when you inflict pain, something that they don't like, the body shuts down. Do you want that?
No.
So, and I have to say that this is, we can go so many different ways, because some people say just to insert power, they want that, painful interaction. But short of that, majority of people would like to be in a relationship that they're not inflicting conscious pain, unless they're misguided. So I don't know if I answered the question.
Yeah, thank you very much.
That's a good question. Yeah, good answer. Yeah.
Another question, you just brought up the question of porn, as in pornography. Do you feel that fits into sexual expression? And if so, how, why, and is it a very universal factor in sexual expression? Sara?
Sexual expression, meaning that, okay, so actually I like that you use it as sexual expression, because there are some heterosexual men come to me and say they only watch gay porn. Then gay porn. So their female partners are so concerned that, oh my God, my husband is gay. Majority of times that's not the case. They just want two good-looking men, fit, do what probably he can't do. Because, the average time for ejaculation is 5 minutes, right? Depending on the research that you look at. But if you look at it that way, but with porn, with all the injections and, whatnot that, are given to the actors, and the cutting inside the videos and whatnot, usually they are fit. They can go on for a long time, as long as they want. And so it feels good for the man to project what they don't have into something that is the expression of something that they would like. So people use porn as easy access to pleasure. Easy access to pleasure, meaning that I'm looking for a release and I can't be bothered to fantasize, or I don't have the time. Let me just put on something and get on with it. So that's one thing. And if you look at the bounce rate of porn, it's really interesting, because some men, without knowing, women included these days, actually, we are doing some research on that as well. But for men, it's as if they condition themselves for ejaculation issues. Because if you look at the bounce rates of porn, they don't usually stick with one video. They bounce from one thing to the other. And the bounce time, right? So that is the issue as well. Why is it universal? It's easily accessible now. It's everywhere, right? And and free, yes. And the other thing is people have FOMO. If they don't watch porn, they're like, it's so all over the media. Everybody thinks everybody watch porn. You know, they're curious. It's out of curiosity that, you know, and they don't want fear of missing out. They're like, oh, everybody's watching. I'm not watching. Let me watch it, right? And on the other side of it, people watch it, then feel guilty. Guilt goes to shame. And I don't know how much like our colleagues here know about the cycle of shame. The more shame you experience about something that actually makes you feel good and has those endorphin qualities to it, the more reason for you to go back to it. So you watch it, you probably masturbate, come, and then it feels good, feels bad, because what did I do? You know, I used porn. And then shame for a little bit, shame goes to grief, grief is lack, then I need to do this again. It turns into a compulsion.
Yeah. And another thing that people sometimes say to me, we've had one or two questions like this, is you mentioned also in passing that they have a fantasy of pornography as being something to aspire to. But in real life, as you say, there's so much injections and pills and medications that make it unrealistic. And although people aspire to it, they don't realize that this, in fact, isn't real life. This isn't real sex. This is something that you can aspire as best you can, but you'll never, ever be able to achieve what the film stars achieve.
That is so true. Even for women, for example, how many cases you see more than me, probably because you're dealing actually with genitals. It's interesting how many women bleach all the way, because in porn the labias are tucked in, the you know, everything is pink and everything is, you know, a certain look, and they want that way. And then with labiaplasty, the aftermath of it, I have to deal with it, because one, it's a new place for them. They can't connect with it, at least the clients who come to seek help from me, and the nerves are damaged and pain.
Yeah.
You know, a lot of people experience pain after.
Yeah. Now, this bleaching is a problem. In Cape Town, what we have, Sara, is all sorts of sexual problems because it's considered a honeymoon destination. And I have noticed that also in people from the Middle East. You mentioned the Middle East people. It becomes a real problem because they have vaginismus, they have unfulfilled expectations, they have desire problems. And there's lots of hotels in this area around this magnificent place of the hospital in which we practice. And it's not uncommon to have people knocking on the door, walking in and say, well, we're on holiday it's our honeymoon and we live in place X and we can't consummate. And you've got 15 minutes, maybe 30 minutes to work out a problem which is actually unsolvable in 30 minutes. So yeah, it's a huge problem to fix complex problems in 30 minutes, Steve.
Yeah.
What would you do under those circumstances, Sara? They're here for a week and they haven't been able to consummate the marriage, and it's almost unfixable in 30 minutes.
Yes. So first, if it's me, I would do a quick history taking just to see if there's anything going on, and then educate them. The fact that they're coming to you and they say they couldn't do it, you know, what is the expectation, what is happening, anatomy, just a quick lesson in that, what goes where. And trust me, I've been there, that I assume that the person knows, and then what they presented to me, it was unbelievable that they didn't even know that what goes there. So, and a lot of men actually think that because it's supposed to hurt and bleed, that's their belief, they actually insert the penis into urethra rather than like a urine opening, rather than a vagina. And they feel like it's achieved, and then they end up in ER. So that's that. Now, to answer your question, one of the things that could be done in that situation, I actually ask them, if they drink alcohol, I say, what will happen if you take a warm bath and then maybe have just one glass, not more, one glass of, you know, wine, and then just start being together. And here's how I would like you to do it. you know. So I will show them about the fingering. I will show them about the, you know, like I will give the analogy of the host and a guest. If it's vagina, you know, like the man being the guest and vagina being the host. So go knock a little bit, just a little bit, you know, hey, hello, and am I welcome here? Little by little, little by little. So this bring down the shame and the guilt and, you know, all that. And if wine is not a thing, oxycodone, like, you know, things that will actually by physiology can relax, give them some relaxation. Sometimes also it provides placebo effect, that because I took this pill, because I took that wine, now I will be able to do it. It was not me, it was the wine that did it. So sometimes this is just quick off top of my head if I'm in that situation.
Yeah. Sara, we have lots of problems also about this cross-cultural thing. We have Black people over here that have very difficult, very different cultures to other people, and sometimes very difficult and very different to know what is normal for them and normal for us. And we have such a thing called dry sex. I don't know if you've ever encountered dry sex.
Yes.
And although it might be, the concept might be foreign, in certain cultures, to other cultures, it's absolutely normal. And that's one of the things that is very difficult to overcome, is not our prejudices, but our disbeliefs of how some people, like some men, think dry sex is great. It's to be desired, because if a woman does lubricate, then she's promiscuous, or she has many other problems that haven't been communicated to him. And that is a foreign concept to us that sometimes requires quite a bit of overcoming and education, which isn't taught in the medical schools. You won't have any of that in a medical school.
No, no, I'm with you. So, you know, I've done a research. It was a 6-year research on genital practices around the world with my colleague, Raika Kumro. One of them was dry sex, and the herbs that were used, the
Yeah.
way that women do that, you know, like, and that's a whole different story on its own. The reactions it causes, allergies, and, you know, infections, you know, whatnot. But in those situations, one of the things that education is everything, but when they know that we are educating them. So for example, I'm going to take a guess. You look to me as a person who is white, who is a male, educated, you know, doctor, right? So if an average person comes to you with a different skin color, let's say a Black person comes to you, they don't accept your way of being sometimes, right? So one of the things that happen, we need to really shift it around and make it about them. So for example, if we can teach them, if that person plays with his penis, if that person masturbates, for example, right? If we help them see that, look, I'm going to ask you to do to use this, you know, give them a lubricant, right? And then use this to masturbate for the next month, and then come, we will talk about it. If you have that luxury to see them again, right? And then just teaching them little by little about how this could actually help the skin of their penis over time. Because if it's too much of a friction, it might actually hurt the skin of the shaft of the penis as well, right? So
Yeah.
these are the things that, you know, make it relevant to them. That's one. The second one is, you know what? The fact that she gets wet with you. Wow, well done. What did you do? You know, so we need to really speak their language to be able to, you know, talk to that ego. If, you know, like a yeah, that delegator, facilitator, authority, you know, like we need to really speak the language that works for them, so that it works well. I as a woman, I can see myself how I'm explaining it to him, you know, but you need to find it within your stature, like within your status, as how are you going to communicate that so it works for them.
Yeah. So that's another thing, of course. Now, you're a woman. Sometimes it's important for men to relate to men and women to relate to women, and vice versa. But we have found also that this business about women have to, if they are sex therapists, we have a few in this country of women that are set themselves up as sex therapists. And they feel that part of the uniform is to have a black leather miniskirt with high heels. And I mean, that is so wrong, and it is so off-putting. And yet in this town, our best sex therapist was a granny that was so sort of non-sexy in the sense that she didn't dress the part. She was just so wonderful. She felt like everybody's Oma, that it was so much easier. So it was so much easier to relate to her and for her to relate to us and to her to be helpful than a sort of a vamp dressed in a leather miniskirt with high heels and fishnet stockings. So do you also find that, is that a universal observation?
That's absolutely what I was referring to when I said in Instagram or, you know, whatnot. It's very important for people. Look, people sometimes want to go to people who look like they're still having sex. So kind of they understand, like, you know, parents want to get parenting advice from people who are parents themselves, right? The same thing. But if you are doing it, overly doing it, you're actually doing a disservice to the client. The other thing is, you don't know who comes through that door. Like I remember one time, Daily Mirror in England, they asked me to go for a photo shoot. This is so common, so common. I arrived and they wanted me to wear their closet, their wardrobe. And as a part of the wardrobe was leather boots. All I could think about was one male client that I had fetish for
leather boots.
leather boot. And I was thinking, I can't do that because I don't want to be a part of his fantasy, you know? So then I will lose my power as the therapist. So these are the things. Although I have to say, there are people who are somatic workers who get involved with clients, you know, who actually have body-to-body touch. That's a different type of therapy, which is valid on its own. But if we are doing cognitive therapy, if we are doing, like, you know, within the profession that we chose to do, I personally have very strong opinions about that.
Yeah. Well, Sara, I'm afraid that we seem to run out of bandwidth and out of time. It's been wonderful having you over here. And do you ever travel to South Africa? Have you ever been here before?
I would love to, actually, because now my book is in South Africa. I'm looking forward to being there and, you know, meeting everybody, talking about love and sex and all that.
Well, we're having a very big international meeting here next year in October. It's the International Federation of Obstetricians and Gynecologists. It's a world meeting, and we have it every 2 years or every year in the FIGO. It's called the FIGO. Do you speak French? Do you understand French? The Fédération Internationale. So that's going to be here, and maybe we can get an invitation for you to come and have a few days with us over here in this Congress, Steve. But it's been wonderful, and I'm going to ask Steve then to thank you very much indeed, Steve.
Well, thanks. I mean, it was wonderful to you, and also just to see how you handle some of those questions as well, Pete. I mean, it's a wonder. This has been a great conversation to be part of, actually, and I mean, I think you've maybe given us more questions than answers in a way, because, you know, the way we interact with our patients is important.
Which is good. We need to be challenged,
and we need to challenge the way in which we, you know, bring in our own background and perceptions about certain things. So I think you've given us a lot of food for thought. Thanks so much, and thanks for your time. I know it's you know, you've taken time out of your day to you know, be part of our day, and we do appreciate that.
It's been wonderful,
and we do look forward to having you in Cape Town quite soon. It's a year's time, so I'm sure Pete will get in touch with you about that.
Yeah. Thank you so much, Sara.
Thank you.
Wonderful, and thank you, and have a wonderful day. I know it's morning in Los Angeles, isn't it?
Yes, yes. And I wish you a wonderful evening. Thank you for the honor of being here today. Thank you.
Thank you so much, then, Sara. All the very best.
Thank you.
And good day.
Thank you.
Thank you. You too. Thank you. Bye.